Hello, everyone, and welcome to today's webinar on birth trauma and maternal mental health. My name is Adrienne Griffin. I'm the Executive Director of Maternal Mental Health Leadership Alliance, and on behalf of everyone at MMHLA and Children's National Hospital, we welcome you to today's webinar. This is the first in a four-part webinar series called Delving into Maternal Mental Health, and it is made possible by a grant from the California Healthcare Foundation. Next slide, please. So again, welcome and thank all of you for taking time from your busy day to be with us. And also thank you for your commitment to improving the health and well-being of mothers and birthing people. Next slide, please. So we've all been doing webinars for a good long time now, but just as a refresher, if you'd like to ask a question, please use the Q&A button at the bottom of the screen. You can also show captions, selecting the captions button, and show reactions button to share an emoji. At the end of today's webinar, we will be sending a short survey so that you can provide more feedback and ask questions. Next slide, please. So just a word or two about Maternal Mental Health Leadership Alliance. We are a nonpartisan 501c3 nonprofit organization dedicated to improving the mental health of mothers and childbearing people in the United States with a focus on both policy and health equity. Next slide, please. In today's webinar, we will have three parts. First, a brief overview of birth trauma. Then we'll hear from a mom with lived experience about her traumatic birth and experience with having a baby in the neonatal intensive care unit. And then we'll be uplifting a program that supports families who have traumatic experiences during birth and in the NICU. Next slide, please. And after this webinar, we will email you directly with several very important things, a brief survey to get your feedback on this webinar, PowerPoint presentations that are shared during today's webinar, a recording, and our brand new fact sheet on birth trauma and maternal mental health, which we are putting the finishing touches on as we speak. Next slide, please. So a few important notes about today's webinar. Some of the information may be challenging. We are going to be talking about birth trauma, or as some people refer to it, traumatic childbirth experience. We'll also be talking about NICU trauma, and both can lead to significant and ongoing PTSD symptoms. So please take a moment if you need to. Some of this information may be a little bit challenging to process. Next slide, please. And a quick overview of today's featured speakers. We're so excited to have with us Dr. Erin Sadler, who is co-director of the Mood Disorders Program at Children's National Hospital, as well as Lamia Sagir, also at Children's National. Dr. Sagir runs the NICU. She's in chief of neonatology. And also with us is Allison Meisler, who is a research associate at MMHLA, and she'll be sharing her story. Next slide, please. So just a few key facts about maternal mental health, just so we're all oriented. Next slide, please. Most of this information should probably be fairly common knowledge among this audience, but 1 in 5 mothers and childbearing people are impacted by mental health conditions either during pregnancy or the first year following pregnancy. They are the most common complications of pregnancy and childbirth and impact about 800,000 families each year in the United States. We also know that mental health conditions are the leading cause of maternal deaths. In fact, suicide and overdose combined account for approximately 225 maternal deaths each year. Next slide, please. The cost of these illnesses is significant. It's about $14 billion each year, or $32,000 per mother-infant pair. And this accounts for poor birth and poor health outcomes, as well as lost wages and productivity. As many as 75% of those impacted by these illnesses go untreated, increasing the long-term risk of negative impacts on mothers, babies, and families. Next slide, please. And we know that certain individuals are at increased risk for experiencing these conditions, including individuals of color, those impacted by poverty, as well as military service members and their spouses. And of course, most people at this point understand that it's not just postpartum depression, that there are a range of maternal mental health conditions, including not only depression, but anxiety disorders, obsessive compulsive post-traumatic stress disorder, bipolar illness, psychosis, and substance use disorders. So as we like to say here at MMHLA, it's not just postpartum and it's not just depression. Next slide, please. So hot off the presses, right after this, we will be publishing our new birth trauma and maternal mental health fact sheet. Again, we'll be emailing that to you after the webinar, as well as posting on our website. Next slide. Okay, so we are ready to delve into maternal mental health. We are going to start with birth trauma, overview and research. Next slide, please. And leading this discussion, we are so thrilled to have with us today Dr. Erin Sadler, who is co-director of the Mood Disorders Program at Children's National Hospital. Welcome, Dr. Sadler.
Thank you so very much. I am thrilled to be here speaking with you all today about a topic that is near and dear to my heart. And as it's already been mentioned, I am the co-director of our Mood Disorders Program here at Children's National. I like to think that the work that I do, I describe it more like a snow cone, while on top it may seem like I'm doing a lot of things, but when you boil it all down, it's kind of one big mush of a lot of related topics. And so I specialize in the treatment of anxiety, depression, and trauma disorders from the perinatal period through early childhood and into adolescence. And spent some time working as a birth doula while I was doing my graduate training, as I quickly realized how challenging it can be for caregivers who have recently given birth to then need to bring their newborn or infant in for therapy. And so I figured, why not figure out how to help them both at the same time? And then went on and did some perinatal specialization as well. For the information today, I have no disclosures, but we'll begin with, next slide, a quick overview. So again, because we are talking about a very traumatic for many people topic, just have some webinar self-care ideas. Since most folks are off camera, please feel free, if you need, take a break for as long as you need. If you need to take a quick, what I like to call 3-6 breathing, breathe in for 3 seconds, a slow exhale for about 6, do that 3 or 4 times. If need be, grab a cup of water, or soothe yourself by emphasizing one of your senses, whether that's lighting a candle, having some nice quiet music in the background while we're going through today. Right, next slide. I wanted to start us off with just some defining terms. When I use the word stress, when I use the word trauma, when I use the word PTSD, making sure that we're all on the same page to start. And our upside down triangle here is really indicative of what we're looking at in terms of prevalence across human experience. And so stress by default is actually one of the more common experiences of life. It is part of the human experience. This is kind of our typical response and reaction to situations that require our attention or our action. In appropriate doses, stress can be really, really helpful if we need to focus our attention on a work project, a test, whether that is focus our attention on driving because there's a lot going on. The moderate amount of stress that we experience there is really, really helpful for us. When we are experiencing a situation that is overtaxing our stress response, we may be tiptoeing into what we consider this more traumatic experience, where the event could be something frightening, something unexpected, or even dangerous or violent that really overpowers our ability to cope. For many people, general stress and even traumatic experiences, as it mentions here, are incredibly subjective, meaning my interpretation of something that is stressful for me may be different than another person. We could actually be sitting in the same place at the same time, having the exact same experience, but internally what happens for us can be very different, and how we respond to that can look very different. When we are trickling down, thankfully prevalence-wise, while we're all experiencing stress as a universal human experience, when it comes to more clinical diagnoses, so moving into post-traumatic stress disorder, this is the mental health disorder or condition that is triggered by either witnessing or experiencing a significant stressful event. And that experience in and of itself really does, again, impact a person's ability to cope, and the symptoms themselves, a lot of that post-traumatic stress, the symptoms persist long after the event has passed and can interfere with things like work, family, even social relationships. So what I am going to ask everyone in the audience to do is really think about how, when we're considering stress trauma and PTSD, when we are engaging with birthing and even non-birthing people, what that can look like for them as we think about some of the symptoms themselves. Because again, even in the land of PTSD, experiences don't have to be direct. They can be witnessed or even learned of. And so when we think about non-birthing caregivers, medical workers, friends, family members, that we all can experience, even as it relates to birth trauma, our own traumatic responses to someone else's maybe direct lived experience. Okay, next slide. I include potential in here, more so to highlight the notion that while these experiences themselves are stressful by default, childbirth is stressful because it requires a lot of focus, a lot of attention, there's a lot going on. And because everyone's experience may be a little different, that these can be potentially traumatic experiences for folks. But the top four, if we will, if we were to categorize them, include significant unplanned medical interventions or even deviations from birth plans. And so that can look like unplanned C-sections, unplanned hysterectomies, even just the use of interventions like forceps or vacuums to assist during labor and delivery. The lack of support, a lot of that can be around social support, or even communication with medical teams during the labor and delivery process or even postpartum. And most notably for this particular traumatic experience is that it's the subjective experience of being really powerless. And so having a lot of your life and process happening to you versus having a hand and a say in what is occurring around you. Then next up will be severe medical complications for the mother or the birthing person. So once more, this may look like hemorrhaging, tearing, prolapsed cords, or even just injuries that can occur during labor and delivery, again, or immediately postpartum, meaning while we're still here in the room, still in the hospital, or we get home and we're needing to now come back to the hospital for some reason. And then lastly, which we'll talk a little bit more about with our lived experience, and then Dr. Sodier as well, are severe medical complications for baby and the newborn. So that can look like injury during the birth for baby, even NICU admissions themselves, or challenges with breastfeeding that can, again, subjectively become very traumatic experiences. Next slide. Okay, now this one is a little bit heavy. It's certainly meant to have as more of an FYI as we're thinking about what birth trauma, PTSD specifically can look like when we're talking about those symptoms that are long lasting, persisting well after the birth experience themselves. So starting with one, just experiencing some sort of traumatic event, whether that's witnessing it, learning about it. So again, it can include birthing and non-birthing caregivers. Next up, what we consider intrusive symptoms. And so similar to as it reads, these are symptoms of being able to have or having involuntary memories or even just images in one's mind, dreams or flashbacks of the event itself. And because of how intrusive those are, what we often see with birth PTSD specifically, or even avoidance, and often that's avoidance of people, places, activities, objects, situations that can bring on distressing memories of the events, also known as trauma triggers. Some of those can also be sensory, so smells, sounds, even physical touch that can bring someone back to a memory of an experience that was quite traumatic. Even negative thinking. So what we tend to see are switches in just how we're thinking, general mood. So we may have someone who was happy-go-lucky, had an incredibly traumatic birth, and now the thinking that they're experiencing, statements that they may be making, may look or sound quite negative, whether it's about themselves or about others. We tend to see a large shift in mood that has a really, really tough time of brightening up. So that may be persistent fear, horror, feeling angry, even guilty, or detached or uninterested in engaging with others. And then lastly down here, this kind of hyperarousal reactivity. Many birthing people describe feeling on edge or jumpy, feeling like, you never know what's going to happen next, having pretty significant sleep problems, whether that is I'm sleeping all day, every day, or I can't fall asleep, or once I do fall asleep, I'm up in the middle of the night 3 or 4 times. I'm waking up far too early and only getting a couple of hours of sleep. And I don't know if it works the same for you all, but when I am not sleeping, my mood is not all that great, and I don't find myself concentrating nearly as well, focusing on things that again need our attention, and may need us to do things at, like, caring for a newborn, perhaps. So knowing that these symptoms in and of themselves have direct impacts on caregivers, and then by nature, direct impact on newborns. Next slide. What I have listed here are just some examples of quotes that we may see for birthing people who have experienced a traumatic birth. Things like, "This is all my fault," "Healthcare providers can't be trusted," "I'm never having more children." We may see a lot of negative commentary, negative thoughts around that. When I was describing the avoidance piece earlier, when we're thinking about people, places, reminders, activities, that medical care we know is quite important. However, if a medical provider, if I'm associating a medical provider with a trauma that I've had via birth, it is highly unlikely that I am going to enter into a medical system, into medical care with the same, perhaps, ease, level of interest, level of calmness that I may again feel on edge, may even avoid. And similar with babies, that babies in and of themselves, the newborns, in true form, can become their own trauma triggers and reminders of the experience. And subsequently, we can observe the same types of responses, whether it's negative thoughts or feelings about baby, difficulty engaging with babies. And so because of that, some of these negative outcomes that are listed here for coping, parental stress, what we do know is that birth PTSD has high comorbidity with depression, up to 90%, so almost a 1-to-1 in some studies. Potentially low birth weight for babies, depending on where the stress is occurring, even lower rates of breastfeeding, and then links with infant cortisol and eating and sleeping problems. And so baby stress response changes and their own regulation changes as well in terms of how they're able to get their nutrition. Next slide. Now, prevalence rates of birth trauma are what I'll in short say is we don't exactly know. And part of that is related to birth trauma, PTSD, or the notion of trauma during birth, labor, delivery, the immediate postpartum period. We are a little behind the postpartum depression trail, if you will, where the importance of being able to both assess for, reflect on birth trauma is newer. So right now, as it stands, some of the rates that we know of across studies are somewhere between 4 and 6% for birth trauma, depending on samples that we're looking at. So in high-risk samples or community samples where there may be a pregnancy complication, the rates tend to be higher. And then what we're noticing is that it may be upwards of 1 in 3, give or take, for NICU caregivers. So when we think about the NICU time being potentially traumatic and the birth in and of itself, it makes a ton of sense that our NICU caregivers are likely having far higher rates of birth trauma symptomology. Next slide. This is another chunky one, and so more of an FYI. The biggest high points here when we're thinking about risk and protective factors is all of the potentially traumatic events that were described before have links to their own risks. And so if I am more likely to have intervention because of my my physical health, then I am more likely at risk for developing or experiencing some sort of birth trauma symptoms. So when we're thinking about medical risk, whether we have operative births, kind of being the leading of the pack for medical risk, or health complications, maybe cardiac disease, prior mental health history, or even simply being counseled for pregnancy or birth related factors. So the notion of there's something may be going on, even if I learned during the counseling itself that nothing is, but the fact that I had to enter into this conversation, the fact that we had to schedule this meeting, my stress response goes up pretty quickly and can put me at risk for having increased stress responses once it's time to deliver. Because again, this may be sitting in the back of my mind, regardless of what you told me 3 months ago. Now I'm stuck with this and it's with me until who knows when. And then similarly with psychosocial risk, that the leaders of the pack for risk include lack of support during birth, negative subjective birth experiences. Again, so it could simply be feeling powerless, feeling as though the individuals around you are not listening to you, that simply feeling subjectively distressed is more than enough to increase risk. And then same thing for prior mental health history as well. But thankfully, if we can think about ways that each one of us, when we come in contact with birthing and even non-birthing caregivers, where are we fitting in this kind of medical risk or psychosocial risk category? Are there ways that we can kind of intervene on some of these potential factors here? So a lot of that comes in the land of just social support. That's simply asking, how are you today? Are you okay? Finding ways of screening more consistently or universally for trauma or trauma experiences. That way we know if we are moving towards higher risk, how can we then make the recommendations for facilitating different types of supports. Separate from that, just education around PMANs, that sometimes folks have no idea what they're experiencing. They just know something doesn't feel right. So by simply educating, it can help quell some of the stress in and of itself. Just give it a name. That is stress. Like, yes, I knew something was up. Thank you so much. This makes a ton of sense. And then it allows us to move towards different types of support. So that may be therapy, it may be medication, it could look like just lifestyle changes. How do I adjust my schedule to increase sleep, get out more, hang out with my friends, or find a peer group that I can be involved in. All right. Last slide for us. I know this is a speed birth trauma intro. I hope it gets everyone's interest flowing. So in short, birth trauma is likely underestimated in terms of how prevalent it may be, and it's more common than we likely expect. Responses can greatly vary and present themselves in even unexpected or unexplained ways, or what seems unexplainable. So if we had 3 takeaways, it's check in with caregivers, whether that's through their prenatal time to postpartum. It could be as simple as how are you doing? How are you feeling? How was labor and delivery for you? Kind of allowing the space for there to be some reflection. Increasing social emotional support. And that can be you can become the support or just refer out. Ensuring that we have doulas available, peer support groups, increasing daily activities, facilitating therapy, and then building, depending on where folks lie, building teams that are ready to act, whether that's trauma-informed care training, getting comfortable with simply asking, and collaborating with community partners to catch and connect with families. That is where I'll pause.
Oh, thank you so much, Dr. Sadler. That was a terrific overview. And I actually just want to emphasize one thing that we've learned is we're learning more about birth trauma, that it's really in the eye of the beholder. And I think you kind of mentioned this early on, but something that we really want to, impress upon everybody. And also that, a birthing person or the caregiver can experience symptoms of PTSD or post-traumatic stress without a diagnosis. So, right, we show those diagnosis numbers are pretty low, but that a lot of people experience symptoms without necessarily getting a diagnosis. So, yeah, just a couple of highlights there. So grateful to you. That was a terrific overview. Thank you. And we are now going to pivot and hear from Allison Meisler, who is a research associate with Maternal Mental Health Leadership Alliance. And she is a mom of 2 little girls. And she experienced actually traumatic births with both of her births. And we're going to hear from her specifically about what she experienced around the birth of her second daughter, whose name is Claire. So Allison, welcome. And we're really looking forward to hearing your story. And I do want to just let people know that this is a pretty dramatic and traumatic story. So just sort of, be kind to yourself if you need to step away. And big hugs to Allison as she shares her story. So thank you.
Thank you so much, Adrienne, for that introduction. And yes, thank you all so much for joining us today. I wish to express my appreciation to all of you for giving me this opportunity to discuss and have a platform to discuss my experiences with postpartum PTSD, the journey I had as a NICU parent, and the intricacies of maternal mental health that have intertwined throughout my motherhood journey. I am honored to be a staff member with MMHLA, and as part of the reason why I'm drawn to this work has to do with the experiences I'm about to share with you today on my story. So most importantly, I hope and want to give hope that it is possible to find healing after a traumatic birth experience. So we're gonna delve in. So as Adrienne mentioned, I'm a mom of two wonderful daughters, ages 5 and a year and a half. I will be sharing, as mentioned, about the birth of my second daughter, Claire, for the context of the webinar. So for my second pregnancy, I was considered a high-risk pregnancy because I had experienced complications and also traumatic postpartum period with my first daughter, where I experienced eclampsia with seizures. I attempted to safeguard my health as best as I could for my second pregnancy by consulting with a high-risk OBGYN and taking necessary medications and precautions as I was directed to do. Despite proactive measures for medical care and diligence, in December of 2022, I was 31 weeks pregnant and I contracted COVID. After a week or so later, I had a grand mal seizure. I was quarantined at home with my husband, and he was able to call 911. And once I regained consciousness, the paramedics had just arrived. Thankfully, my oldest daughter was 3 at the time and was not witness to the actual seizure event. I was rushed to the ER and had an emergency C-section after also being diagnosed with preeclampsia, along with continuing to have multiple seizures while in the ER as well as in the OR. Since my baby girl Claire was a preemie, she was whisked away to the NICU immediately after delivery. And since my husband and I were still COVID positive, we couldn't be with her. Next slide, please, Mia. Thank you. First time I saw my baby was actually via FaceTime, which is in the middle picture. And this is a screenshot of that I took. And due to COVID, we weren't able to visit or hold her until she was about 9 days old. The first few days that followed Claire's delivery, they are still a blur. I experienced postpartum seizure symptoms along with crippling anxiety, and was very scared and fearful of having any more seizures. I had a lot to deal with side effect wise as well, from having a magnesium drip to address the preeclampsia and adjust to starting seizure medication. This is a very abbreviated version of an incredibly scary situation and much more detailed story, but much of it I actually cannot remember. That is one of the traumatic aspects of my daughter's birth, my incomplete memory of what happened. I have pieces of memories from that day, but it is all very disorganized. But there are also so many things that were traumatic about the experiences themselves. One was knowing that my 3-year-old had been very scared by the EMT showing up at our house and watching me leave the house in an ambulance. I worried about my husband, who had now witnessed me have multiple seizures, and the impact that that experience was having on him. My 3-year-old did not see me for a number of days, and we had to explain in an appropriate but gentle manner to her about why her sister didn't come home with us when I did return home. Not having clear memories of labor and delivery, I was so disoriented. I have little fragments of memory, but it's very scattered and almost in a dreamlike state. I felt paralyzed by fear and that I would have more seizures, not being able to go and hold Claire or be with her in the NICU. Excuse me, sorry. In the NICU. And I had to continuously also return to the hospital where I gave birth to my baby to visit her in the NICU. The NICU environment itself was extremely stressful for me. Lots of alarms and beeping sounds, which reminded me of my own experience in the ER and hospital. I also worried sometimes that something terrible would happen to my child or someone else's child while visiting the NICU. I also felt unprepared to take Claire home and care for her after spending 32 days in the NICU. However, despite the feeling guilty about this, I found relief in not being allowed to be in the NICU. I was in such a disconnected, dissociated state that adding another responsibility would have made the situation even more overwhelming for me. Beyond the difficulties of caring for a premature baby, I was definitely aware of the impact that these experiences were going to have on my mental health and well-being. Through tears and fears, though, I forced myself to take proactive steps to best protect and address my mental and physical health struggles. Those proactive actions included, I acknowledged that the experience I had was hard and it was scary and traumatic, and it was okay that I was not okay. But I tried to remember that it would not be this way forever. I started to see my therapist, whom I was already seeing, more frequently. I spoke to my OBGYN about getting put on antidepressants and anxiety medication to address postpartum PTSD, OCD, depression, and anxiety. I asked for help and support from family and friends, and I prioritized resting and sleeping. I was very, very fortunate to have family and friends who were able to fill in for me while my brain and my body healed. The process of learning to live with your anxieties, fear, and trauma is long and can be a lonely road. And I don't expect myself to ever really heal from it all, but rather learn to live to have a space for it in my life. A therapist of mine often referred to my trauma as it being a large ball that was bouncing off walls in a room, constantly pushing a fight or flight button that was also in the room. The point of the process of therapy, medications, along with dealing with trauma, wasn't to make the ball disappear, but for the trauma ball to become smaller over time, therefore not hitting the panic button as often, and to help my body appropriately assess things that I was feeling or viewing as a risk or a fear. I consider myself incredibly fortunate and privileged to have had access to essential care along with vital support systems that were already integrated into my life. I also had the awareness to address the issues I anticipated. So, a significant motivator for my advocacy work and involvement with MMHLA stems from recognizing that my experience is not representative of all birthing individuals. I'm acutely aware that my situation involves unique factors and circumstances that shielded me and ensured that I received the necessary healthcare and attention. This awareness drives my commitment to improving medical and maternal mental health access for everyone, as I believe I am dedicated to continue to work towards addressing these inequities and discrepancies. No birthing person should have to face such challenges without the same level of support and care. So I wish to thank you all again for your time and for investing and contributing to improving the care and the lives of people like myself and other birthing people.
Allison. Oh, and there she
And
is.
yes,
There's
that's
Claire. Yay. Yay. I love the name Claire. Allison, you know, that's my oldest daughter's name. And so
Yeah.
we share that lovely bond. Thank you so much for
Thank you,
sharing
Adrian.
your story. We know that you put a lot of time and effort into working on that. And I know you are getting so many loves and hugs coming up from the emojis. And we are just so grateful for you, for your willingness to be so open and honest about your experience. And, you know, yours is objectively quite a traumatic experience. And yet we also see moms who may have had maybe just a small fraction of the things that you went to, like just having, not just, but for example, having a baby in the NICU can be an incredibly traumatic experience. And so that's what we're going to be talking about next, is actually that experience in the NICU. So your story teed this up very nicely. So thank you for Claire for showing up. And next slide, please. The next section that we're going to talk about is birth trauma clinical perspective. Next slide. Our next speaker is Dr. Lamia Saghir. She is the medical unit director in the NICU at Children's National Hospital. She is also a member of MMHLA's board of directors. Thank you, Dr. Saghir, for being with us today and for your time and attention to these really important matters, and also for helping lead MMHLA in the good work that we do. So I'll turn it over to you.
Thank you so much, and happy to be here with you today. I've heard Allison speak before, you know, a few weeks ago, and what I was most struck by is that this isn't a unique experience, that this happens to a lot of families that we see in the NICU. The details of, you know, what got you there and how the trauma happened may differ. But this is a recurrent theme that we see with our caregivers, our moms, our dads, and anyone who comes to the NICU. And I wanted to share with you our experience and how we developed our program. The other thing that struck me, and Allison may not have shared that with you, she talked a little bit in detail about how she interacted with the medical professionals and how they influenced her NICU stay. And she was very frank about the good and the bad. And I remember distinctly, she was talking about how rushed she felt at the end when she was about to leave the NICU and how scared she was, taking this little baby home. You know, here she is in the NICU with all of the doctors and the nurses around her. And all of a sudden, you know, we're handing her Claire and saying, you know, here you go, and you know, who knows what level of support. And she mentioned, you know, being scared, and that stuck in my mind as well as a very common experience that we see. What I wanted to tell you is our healthcare systems, as good as they are, they're designed to give you the same results that you see right now. There's a lot of work to do. And I'm so glad that you're all here because we need to do this together. The system needs to be redesigned from top to bottom, and would love to join hands with you all and see how we can reimagine the postpartum mental health space from top to bottom. First of all, I wanted to tell you a little bit more, next slide, please, a little bit more about our hospital. Children's National is a freestanding children's hospital. In other words, we do not have any adult services at all. And I just wanted to hammer that home. Because even though we're in a hospital, we're healthcare workers, we're physicians, nurses, psychologists, social workers, doulas. We in our hospital in particular, we don't have an adult mental health space. Erin probably is the closest that we come, Dr. Erin Sadler. And she kind of does the crosswork between child psychology and also family care, and helps us take care of our caregivers. But otherwise, we serve the greater DC area, Maryland and Virginia. Our NICU is unique in that because we don't have deliveries, all the patients that come to us have to come from an outside NICU. So they've already experienced maybe a traumatic birth. Then they've been in a NICU at an outside hospital, and then the doctors will call us and say, hey, I need some subspecialty care that I don't have. Maybe it's a specialty surgeon or a geneticist or a host of people, and they ask us to transfer to children. So we're probably the second NICU that they will see. So they've already experienced one trauma of being told that their baby needs to go to the NICU, and then being transferred completely out to a different hospital. We are a level 4 NICU. We're about moderate size, not too small, not too big. But we care for, we cater to about 40 or 50 other NICUs that are out there, in addition to sometimes national and international flights that come to us. The other unique thing about our hospital system is I don't do this in the NICU alone. I also do it in the context of the whole hospital, which is the emergency department. So we also look for, and we ask postpartum caregivers how they're doing in the pediatric emergency department. And our emergency department is one of the busiest in the nation, with more than 100,000 visits. Therefore, being a location where folks can get mental health care in a children's hospital is very unique. And I always say to folks, if we can do it in a children's hospital where I don't have adult care providers, you know, let's reimagine other spaces like community centers, like churches, like WIC, other places that may not necessarily be hospitals. And I wanted to tell you this story because, again, we don't have those resources. And that's the most common question I get from folks. You know, you're well resourced. Next slide, please. So our journey, I really hadn't been aware. I was aware of the stress of being in the NICU, but I wasn't aware of the numbers until around 2016, 2017, when one of our pediatricians invited me to work with her on a research study. And what we wanted to look at is what happens after the NICU stay, that whole year after you go home. And we thought that providing a support service like another parent who's been through the NICU experience, so we call them peer-to-peer supporters or parent navigators in our case. We wanted to ask the question, would that help? You know, if you had a support system for a year after you go home, would that be better than not having one? And I'm showing you here the results of our study, and this is how I developed our program and thought about it and how we got into this space. Sorry, go back one more slide. So in 2016, 2017, we enrolled about 300 families, and we asked the questions of, how does a peer supporter affect postpartum mental health? How does it affect outcomes such as emergency room visits, immunizations, self-efficacy? Does it increase your stress? Does it increase your anxiety? We weren't specifically looking at birth trauma per se, but I was astounded. We found out that about 45% of our parents, so moms and dads, they experienced depressive symptoms. So they screened, they were very highly positive. They had stress. And the literature in the neonatal world tells you if you're premature, because you stay longer in the NICU, you're experiencing more stressors, you tend to have more depressive symptoms. But that wasn't the case in our situation. We found out that even if you have a full-term kid, if you're exposed to stress, you're gonna feel it. And also, if you stay longer in the NICU, you're going to have more depressive symptoms. We also found that depression and stress go hand in hand. So if you are stressed out, you're more likely to get depression. And of course, as Dr. Sadler has mentioned, if you don't have the social support, you are more likely to get a mental health problem. So this kind of seemed in line with all of what we knew from the literature. But what was new and what was astounding was that this wasn't happening while the caregivers were in the NICU experiencing a sick child. This was when they were going home. So this was, as Allison reminded me, this is at the time when everything went well, you're getting discharged, it's a happy time, and you're trying to take your baby home, but at the same time you're experiencing perinatal mood and anxiety disorders. And this really shook me, because nothing is 45%. Even when we look at the pandemic, the numbers, 45% of people didn't develop COVID. So the numbers were just so overwhelming. Next slide, please. That we had to do something about it. This has been about 6 or 7 years in the works, and it has been a lot of grants, a lot of outreach, a lot of fundraising to develop a program. What we did was we reached out to our social work team, psychology team, and together with the clinicians, we developed a program. It was built little by little. At first, we only had half a full-time FTE, even less than that. And that person was housed in the Family Services Social Work Department. And on occasion, she would come in and she would check in with the families and say, how are you doing? We started with postpartum depression. So most of my slides are around postpartum depression, because that's kind of, as Dr. Sadler had said, the bulk of the work is done in that venue. And we would screen, and we would, it would be lucky if we got, 1 or 2 people. My other partner in crime is Dr. Lenore Jarvis, and she had the same interest. We worked in the same hospital, but we didn't know each other. And she also noticed that in the emergency room, moms would come in the middle of the night, she'd check out the baby, and really there was nothing wrong. And in actual fact, a lot of them probably, this was the mom having a mood and anxiety disorder. It manifested in, immense anxiety to bring the baby to the emergency room in the middle of the night. And we worked in silos. And finally, once we put our arms together, we figured out how to leverage one team for both sites, for the NICU and the emergency room. What we currently do is we try to reach every birthing and non-birthing caregiver at around 2 weeks, and then every month thereafter. And we start off with the Edinburgh postpartum depression screen. It's a good way to get into a conversation of how are you doing? So after the medical team has seen the baby, talk to the parents about the infant, here's a chance to focus solely on the caregiver and check in with them. And currently, we can identify 100% of all of the parents that need to be screened and talked to, but we only manage to talk to about 80%, and those who will even take the screen and we will approach them. Those that want to talk to us are around about 70%. A lot of the time in our NICU, the lengths of stay are immense. People go back to work. They don't want to pick up their phone. They've been screened at their OB, which is over the years now has become better. When we first started, it was much less than that. And slowly, we developed our team and got a handle on, the approaches and the screens. The problem, next slide, please. The bigger problem of not being able to reach them in the unit again, we're starting to look at technology solutions. So we're trying to partner with new startup companies and other companies that are out there to do remote screening. You can see that the screening, the positivity rate is high, but look at the care coordination and the touch points. The average touch point is 56 times. The highest touch point may be 375 times, and that could be between text messaging, phone calls, engaging with, any of the platforms out there. And most importantly, we managed to get Dr. Sadler on board, and we coordinate and try and refer back to her. So what the idea of working with Erin was, we wanted to reimagine the system as a one-stop shop. So if you're in our unit and you're experiencing perinatal mood and anxiety disorder or birth trauma or something else, you have the ability for you to self-refer, or when we engage, when our team or our perinatal mood and anxiety team engages with you, they can refer. When our medical social workers engage, they can refer to Erin. So that we try to develop multiple channels where we can bring the service to the bedside. So if you're in the NICU, Erin can come to the NICU and talk to you, which is not something that is available in most NICUs. So I wanted you to keep that in mind. Next slide. And look at what we did. 2018, we were screening about 20, maybe 20 patients a month. And now we're up to about 60, average about 50 to 60. We talk to a lot of people. And again, it's all about asking them, how are you doing? Next slide. And our team, we like to think about, so what, you talk to them and what happens. So we like to think about it as, if everybody's okay, we still are going to give you universal support, right? This is Dr. Kazak's preventative model. And it doesn't mean that because you don't feel any mood and anxiety disorder, or you're not traumatized now, you're not going to feel it later. So we give a baseline education about what it is, what it could be. If in a week or 2 or 3 or 10, you're having feelings, this is what it is. So we name it. We try to normalize it. Those that are having risk factors or really experiencing acute symptoms, there's an opportunity to do a targeted approach. We like to think of it as a Band-Aid, not a long-term approach, but maybe that's what you just need at that time. Just a Band-Aid to get you through this time period. And then those that are very high on the, there's persistence of symptoms, they're escalating, they are high risk factors. This is where we're able to bring in Dr. Sadler and the rest of the team. And also we're able, because we're an inpatient unit, we're able to do a little bit more of longitudinal support. Next slide. I just wanted to give you a sample of some of the things that we're doing. So it's not just about also psychosocial support. It's also about digging a little bit deeper as to the why. Why is this happening to you? Why are you acutely stressed? And you probably all on this call know this, but sometimes it's not just about the baby being sick. It's about everything else that's going on, whether it's the finances, homelessness, food insecurity. And these are some of the things that our social workers have done in the emergency room and some of the other services that they've provided. And here it paints a very good picture of a web of the social factors that are happening on the outside intertwining. And here it's also about the village that's going to wrap around the family to get to the core of why this is happening and why the stress is occurring and why the mood and anxiety is occurring. Next slide. Finally, I would be amiss if I didn't mention the whole team at Children's National. So it's not also about the clinicians and the individual unit like the NICU, but we reached out to. So I work with the emergency room, but we've also reached out to the primary care. The primary care team, and together we built a whole perinatal mood and anxiety task force, and we collaborate and we learn from each other. We resource share. Our institution has embraced it as one of our strategic goals for the year to increase our mental health screening for caregivers across our institution. We have wonderful partnerships with external partners and community, and we're very heavily invested in advocacy on multiple levels. So it has started to be, it's lovely to be a movement. We published all of this, and the references are there if you guys want to read about our experience. Next slide. And these are some of the things that we've worked together in our organization on. How do we communicate? How do we screen? What's the best protocol? The billing is going to come up, you know, if you're doing this work. Cultural competency, diversity, equity, and inclusion also included in there. But these are some of the things that we work on. Next slide. So I hope I have given you kind of a whirlwind of what we've done at Children's National. And I always say, you know, if a hospital, a children's hospital can do it, you know, think about all of the possibilities in your environment. Thank you so much.
Oh, thank you so much, Dr. Sagar. It is so great to see what people can do when they put their minds to it. And I love that you and Dr. Jarvis and the ED partnered up on this. I've known about her work for a long time, and it's just so great to see all of these great things to come into fruition. So we're going to transition now to our last little piece, just a couple of slides on resources. And Dr. Sadler, I'll turn this over to you.
Thank you. And so again, all of the slides will be sent out. And so I will just mention what is here, and feel free to click away once you receive them. There are a couple of support groups that folks can find. I know if there's interest in peer support, there's a birth and trauma support group on Facebook that is quite large. In addition to that, the Birth Trauma Resources, International Society for Traumatic Stress Studies, including PSI and Prevention and Treatment of Traumatic Childbirth. These are all kind of resource-based websites that have resources in addition to maybe kind of info sheets and additional connections with other organizations or groups. And then at the bottom down here, the PTSD coach for iPhone, if folks are really app interested, feel free to take a gander. The idea is, you know, if we're thinking about, you know, top-down stress, maybe traumatic stress in a way, but maybe not PTSD, even though it is PTSD coach. Feel free to use those as more kind of a individual support, self-guided care. And then the Birth Trauma Association of the UK also has a ton of resources as well. They're doing a great deal of research across the pond if there's interest in some of their numbers as well. And our last two slides, or three slides, screening resources. And I briefly mentioned that some exist out in the world. Links are here for some of the, if you will, kind of top. The PTSD checklist for the DSM-5 is more general related to PTSD. And in answering another question, I'll describe why that could be helpful too. The City Birth Trauma Scale is an additional one, and as well as some of the National Center for PTSD screeners that span different care settings. So it could be primary care, working with children, but screening for parents as well.
Thank you, Dr. Sadler. Real quick, before we move on from the resources, I want to address one of the questions in the chat. And it's somebody who's doing research in this work. And she was worried, is there a Listserve group for practitioners in this field? Just curious if you know. No?
We're budding communities. So what I will say is the folks who enjoy working and doing perinatal mental health, we find our pockets within the greater group. And so PMADs, we know, exist wholeheartedly. And so if we are working on depression, we're likely working on trauma. If we're working on anxiety, we're likely working on trauma.
Right. Okay, great. Thank you so much. So just a reminder, as people start to pop off and get ready for next meetings, after the webinar, we'll send you an email with a brief survey. We'd love to get your feedback as we prepare for future webinars like this. We'll send the PowerPoint, so you'll have all of those links. We'll make the webinar recording available, and we will be sharing our new fact sheet on birth trauma and maternal mental health that has even more resources with books to read, websites to visit, all of that. Next slide, please. All right, then we're going to send a quick poll right now just to get some quick feedback. Did you find this webinar was helpful? Yes, somewhat, or no? Just take 30 seconds or even 10 seconds to do that. We would really appreciate that. And I do want to point out, as people are doing that, that September is NICU Awareness Month. And so very timely for all of this work, since August is coming to a close. Everybody's heading back to school. And we do try to recognize these different awareness months that pertain to maternal mental health. Okay, next slide, please. We've had a ton of Q&A. We're really thankful for everybody being so engaged. We've answered some of those questions through the Q&A function, and I'm going to ask a few to our speakers to see what they will answer. So here's a good question about asking, how are you doing? Feeling like you have social support, or what happens if you don't know what to do when you ask that mom? So I see Dr. Sadler nodding her head. I'll let you take this question.
Yes, a fantastic question, because we do want our support to be genuine. But what can be helpful, I think, if we're thinking about small ways that we can help people, as I mentioned before, stress is universal, and being able to validate one's experience, even if we're not doing much with it, that validation is its own special intervention. How are you doing? If someone is able to say not well, and being able to say understood, it makes a ton of sense. That in and of itself is more than enough for the moment, more than enough.
Absolutely. I'm so glad you said that, because it doesn't need, like, you don't have to have this whole list of resources. Just to say, oh, I am so sorry for what you went through, and acknowledge that, and be human and be present in that moment. Even give that person a hug, touch them, whatever. Like, even that, it can just be like this physical change that you see in somebody, that somebody recognizes that they have been through something that has been very, very challenging for them. Yeah. Thank you. Okay, so I'm just going to scroll through these. Oh, here's an interesting one. I have a daughter who was born with a rare genetic condition. Do you see any research being done on grief and postpartum conditions due to newborn diagnoses? I'm guessing you see a lot of this. I see Dr. Sadler nodding again, so pass it to you.
I will say, we have a couple of folks here. I know in terms of fetal diagnosis, both prenatally and postnatally, there is a budding amount of research around grief. In truth, there's so much overlap between grief and trauma that in traumatic experiences, we're grieving the fantasized experience, the fantasy of what postpartum will look like. So there's a ton of overlap, budding research.
Yep. And I think that's so important. And I dropped this, answered somebody's question, that, again, trauma is really in the eye of the beholder, as is grief and loss. Like, there's real grief and loss, like with a miscarriage or a stillbirth or a fetal demise. But there's also the grief and loss about, like you said, that perfect childbirthing experience, or the life that you had before you had children. So there's so many levels of grief and loss that go along with childbearing. Dr. Sogger, I'm going to ask you this quick question. Any recommendations for supporting the patients, that would be the parents, through the baby's NICU stay? How can we support them better? And I know there's been a lot of changes to, like, the physical environment of the NICU in some of this work. So can you share anything else on this front?
I'm going to sound repetitive, but I think two main things. One is asking. So that's the repetitive part. We were under the impression when we were doing this work, and I'm going to preface it by, we're a very well resourced NICU. We have a social worker for every family that's in the unit. So imagine that every family gets a check-in from a social worker, no matter what the need is. And then on top of that, we have a perinatal mood and anxiety disorder team that also deals with just mental health, whatever they need, which includes the social workers and Dr. Sadler, and is very well resourced. And despite that, before we started this work, they would say to you, we just know, like, we can tell when somebody's in crisis, but in actual fact, we don't. Unless you start asking, you won't know. And then the other thing that I've noticed is it's multifactorial. It's not just asking them about how they're doing. It's also the why, what's underneath it, and all of the other things that go with the why, whether it's substance abuse. We had one dad that said, I've been an alcoholic for a long time, and I wanted to quit when the baby was born, and I just don't feel I'm a good dad, and I feel I'm letting my family down. And what our team did was get him to where he needed to go, so that he could cope with the situation of having a sick child. So those are some of the, it's not all about the mental health, it's also about all of the other hidden things that we're not seeing. So that's kind of my my short answer. It's complicated.
It is. Any one of these questions could probably be a dissertation as an answer. And so we are at the top of the hour. And so our time together is coming to an end. I wanted again to say thank you to our terrific speakers today, to Allison, to Dr. Sadler, to Dr. Saugier. I also would like to thank our team from MMHLA behind the scenes, Mia Hempstead and Mara Child, for putting all of this together. Here's ways that you can stay in touch. You can follow us, MMHLA and Children's National, as well as Dr. Saugier and Dr. Sadler on various social media platforms. And again, just a quick thank you. Keep your eye out for an email from us with a survey, with all of these slides, with a link to the presentation, and with our new birth trauma fact sheet. Thank you for being with us, and enjoy the rest of your day.